Good morning. Today we'll be reviewing a 24-year-old Caucasian woman with a chief complaint that she thinks she may be pregnant. She has increasing nausea and mood swings over the past 4 weeks. She has a history of illicit drug use and prostitution. She was diagnosed with HIV within the last month and is currently successfully stabilized on methadone. The patient's past medical history includes an HIV infection, opioid dependency, OCD. Her family history is unknown. She smokes 1 pack per day, has 2 to 3 alcoholic beverages per week, a history of heroin and oxycodone use, a history of prostitution, and currently resides with friends or in a shelter. Her medications include methadone 30 mg by mouth once daily and sertraline 100 mg by mouth daily. Her physical review findings, her review of systems, reveals that she is nauseous, jittery, and agitated. She appears thin. She has scarring on her arms from IV drug use. Her blood pressure is normal. Her pulse is normal. Her respiratory rate is a little high at 24 breaths per minute. Temp is normal. She is 5'4" and weighs 43 kilograms. All other exam findings are normal. She has elevated HCG, serum HCG, meaning that indicates she is pregnant. Her ultrasound shows normal fetal development at 6 weeks gestation. Her x-rays are normal. She is negative for hepatitis B, and her HIV RNA copies are at 122 copies per milliliter. Her CBC returned normal. At this time, it is appropriate to begin combination antiretroviral treatment as well as address her opioid maintenance therapy and her pregnancy. The goal of combination antiretroviral therapy is to maintain a viral load between the limit of detection throughout pregnancy, which is 40 to 75 copies per milliliter. And I am recommending initiating the patient on atazanavir and ritonavir, atazanavir 300 mg and 100 mg of ritonavir boosting, and also a combination NRTI Epsicom, which is abacavir, and lamivudine 600-300 mg once daily. Monitor the patient's viral load every 4 to 6 weeks until it is below the limit of detection, and once every 3 to 4 months. Monitor BUN, electrolytes, liver function, and CBC at baseline every 2 to 4 weeks, and then every 3 months. Report any signs of rash to the physician immediately, as ritonavir is known to cause Stevens-Johnson syndrome. It is rare, but it's possible. Monitor blood glucose for signs of diabetes mellitus, and monitor liver function should be evaluated at baseline every 2 to 4 weeks and every 3 to 6 months. In terms of her opioid maintenance therapy, due to extensive drug-drug interactions and improved neonatal outcomes in terms of treatment for neonatal abstinence syndrome, I'm recommending to switch the patient to buprenorphine therapy. Because the patient is on a low dose of methadone right now, it is recommended that the patient can start initiation as soon as possible. So after the patient's last dose of methadone, generally the first dose of buprenorphine can be given within 36 to 72 hours, but is recommended to observe clinical signs of withdrawal before initiating buprenorphine. Tell the patient to report any signs and symptoms of breakthrough withdrawal. Monitor liver enzymes at baseline once every 3 months. Monitor respiratory depression during the first 24 to 72 hours. And monitor for signs of toxicity, overdose, fever, and increased core body temperature. In terms of nutrition during pregnancy, begin the patient taking folic acid 1 mg by mouth once daily for the first 3 months of pregnancy. Counsel the patient on proper nutrition for good fetal growth and development. Also advise the patient on the importance of adhering to obstetrical recommendations and keeping commitments to routine checkups. You can also assess the patient's willingness to initiate smoking cessation and the importance of alcohol cessation during pregnancy. At this time, I'm recommending no changes to her sertraline regimen, as she is being well stabilized on sertraline for her obsessive compulsive disorder. Thank you.